Dr. Chelsea White is going to talk to us about EMS innovations and adaptation during the COVID-19 pandemic. Another national leader in the space of indigenous emergency medicine. Dr. White's an emergency physician at the Department of Emergency Medicine, University of New Mexico, where he serves as EMS faculty and director of the University of New Mexico Center for Rural and Tribal EMS. He's a board-certified emergency physician and in EMS medicine. He completed EMS fellowship at the University of New Mexico Emergency Medicine Residency and emergency medicine residency at the University of Michigan, sorry, Chelsea, and is a nationally registered paramedic. Dr. White currently serves as EMS medical director for Cibola County Fire and Emergency Services, Navajo Nation EMS, Pueblo of Acoma EMS Fire Department, Pueblo of Isleta EMS, Pueblo of Laguna Fire Protection Program, and Pine Hill Emergency Medical Services. He serves on several national and state EMS policy committees and is the president of the New Mexico chapter of the National Association of EMS Physicians. His areas of research interest are rural, frontier, and tribal EMS, community paramedicine, and EMS telemedicine, and he has been a tireless partner and supporter of the Native American Emergency Medicine Consortium. I added that last part. Good to see you, Dr. White. Thanks for joining us.
Well, thank you. I'm really excited to be here. I really appreciate the invitation. Let me just get my get everything queued up here, and we'll share my portion of the screen. And it's the awkward moment here.
We had the share and then we just lost it for a second.
Yeah. All right, so that is what I want to share. And then a portion of the screen. Perfect. All right. At least I hope that's perfect on your end.
Looks good. Sounds good. Yeah.
Great. Thanks a lot. Thanks again for inviting me. I always appreciate being able to present to this group. I will apologize in advance if some of you in the audience have seen a previous version of this talk, because I have given this information as it has evolved throughout COVID-19, several different venues. So this may be not 100% new. Obviously, it is up to date at the end, but please don't give away any of the punchlines if that's the case. I do not have any disclosures or conflicts, at least that I wish to admit to. Real quick, I wanted to talk about the UNM Center for Rural and Tribal EMS. This is a center within the Department of Emergency Medicine at UNM in Albuquerque. And our mission is to support and advance the field of out-of-hospital medicine in rural, frontier, and tribal settings through education, innovation, research, policy, and medical direction. And our group consists of two core EMS physicians. That's me and my wife. And we usually have one EMS fellow. We have one EMS nurse practitioner paramedic and one EMS PA. And we cover multiple rural, frontier, and tribal EMS agencies in New Mexico, Arizona, and the National Park Service. Now, hopefully you guys know what New Mexico looks like. It's a nice square state in the Southwest. There are 23 Native American tribes here in New Mexico. And from an EMS perspective, there are 12 tribal EMS agencies in the state. So reservations that don't have their own EMS agency are usually covered by surrounding municipal EMS agencies. UNM Center for Rural and Tribal EMS provides medical direction for all or part of 8 of these 12 EMS agencies, and medical direction for several of the municipal agencies that cover an additional 4. So we're going to focus a little bit today on Pueblo of Acoma Fire and EMS and on Pueblo of Laguna Fire Rescue. Although there are also some pictures from Navajo Nation EMS and from Pine Hill EMS, which is on the Raymond Navajo Reservation. And I do want to note that all pictures of EMS personnel and of patients are used with permission and are shown with the intent to help EMS agencies elsewhere better care for their patients. And that's really the goal of this whole presentation, is to show you a little bit about what we've been doing, emphasize the fact that EMS is an important component of public health, and to help other agencies look forward to really make EMS a part of their a strong partner in the healthcare fabric of their areas. This is a picture of Pueblo of Acoma Fire EMS staff. Acoma staffs one station 24/7 with 3 to 4 providers per shift. And so they usually have at least one EMT intermediate level ambulance, and sometimes they have a second ambulance on duty as well. Usually that's an EMT basic level. They don't have any paramedics. Hopefully this will change in the future. And in 2020, they ran 693 calls for service. Next door in Laguna, Pueblo of Laguna Fire Rescue has 3 stations staffed 24/7, 8 to 9 firefighters per overall shift. Usually 2 of those are paramedics, so they've got 3 stations, 3 ambulances responding from there. Usually 2 of them are at the paramedic level. The other one is often intermediate or basic level. And in 2020, they had 1,784 calls for traditional paramedic services. And they started a community paramedic program in 2015, which you've probably heard me talk about at one point or another. So starting off with EMS innovations during COVID, we have to start off with pre-COVID. This picture right here is a typical site in pre-COVID EMS. We've got gloves. We've had gloves for years in EMS. I still remember a few dinosaurs of the day when I started taking off a glove to start an IV back in the early 90s, but that was even the exception back then. But if you look at this picture right here, this pre-COVID, modern pre-COVID picture, this patient's being ventilated with a bag valve mask, which is an aerosol generating procedure. We've got somebody about to start an IV, which is obviously a fluid exposure and splashing risk. But look at that lead EMT. She's got gloves on, of course, but no mask, no eye protection. It's kind of almost horrifying right now. And the EMT who's doing the ventilation, some eye protection, but it's perched on his hat, not on his eyes. And then the paramedic, and this may be a little more personal style for this guy, but he doesn't even have gloves on. So he's not even planning on getting his hands dirty. And then you look at the monitor cables, the BP cuff. When were they wiped off last? I mean, I'm sure they were. I mean, there's nothing obviously contaminating those, but what's the policy for wiping those off? This was just not, there was nothing really formalized about this kind of infection control in the pre-COVID era. So looking through the lens of COVID-19, this is a kind of a horrifying picture. I mean, you never see this now, but this was actually good enough for a training photo, because this was a staged photo back in January of 2017 when we were training on this new LifePak monitor. So nothing out of the ordinary in 2017, but definitely an issue once COVID got here. Of course, we did have quite a bit of time to prepare for COVID, because we got to see what it was doing in China, and then Italy, and of course, even on the coasts of the United States. So pictures like that, that last one quickly became a thing of the past and a casualty of the new normal. As far as innovations, the first thing we did was certainly not all that creative. Our step 0 was to develop EMS treatment guidelines that addressed both the disease and the protective equipment. You know, we had been, of course, dealing with the flu, RSV, other respiratory illnesses for many years. We even made it through SARS, H1N1. But EMS never really focused on those illnesses and really focused more on symptoms and how to treat the symptoms. But the first thing we had to do then was to create a treatment guideline in our UNM rural EMS treatment guidelines, which cover many rural and tribal agencies in Arizona and New Mexico. So we released this guideline initially in February of 2020. But even then, we were still aiming it at multiple different illnesses with similar symptoms. But because it is impossible to distinguish between a lot of those different illnesses, COVID versus flu versus RSV, we felt that we needed a unifying guideline, particularly one that spelled out the PPE requirements. And these are now extremely familiar to us, but in February of 2020, this was not standard for sure in EMS for dealing with any sort of contagious illness patient. And this was also when it was the first time that we had to mention evaluating patients from 6 feet away until symptoms could be verified and a mask could be put on the patient. But this, of course, is helpful once you're on scene. But with all of the PPE shortages that we started out with, we really had to have an idea of who we needed to be gowned, gloved, masked, etc. on before arrival, and who was a little bit safer to evaluate in the home without all of that PPE. EMS dispatchers are a really important part of this decision-making tree because they have the caller on the line and they can ask the caller multiple different questions before EMS providers get there. This right here is a specific dispatch triage card from the Medical Priority Dispatch System. It's card 36. It's used by many medically trained dispatch centers, and dispatchers would use this card to decide whether to tell providers to wear full PPE or not. But the problem that we have in many rural and tribal EMS agencies and areas is that very few EMS dispatchers are medically trained. In fact, they're not really EMS dispatchers at all. In most places, they're police dispatchers, or you may be calling the ambulance directly. The phone may be answered by the ambulance crew. So these non-medically trained dispatchers didn't have access to complex commercially prepared algorithms like MPDS. So we had to make our own to start out with that took the fact that our dispatchers did not have any medical training into account. So we came up with a very simple and hopefully very reasonable appearing protocol for them to query the caller. And if any of the questions came up, yes, any of the concerning symptoms came up, yes, that gave the dispatcher the ability to tell responding crew members to put on a full PPE before making patient contact. And it also gave the dispatcher the ability to make sure that the patient and other family members or whomever else might be on scene would have at least a surgical mask. Now, luckily, the PPE issue became less of an issue as the pandemic went on, and some of the agencies were better prepared than others. This is a picture of Pine Hill EMS responding to a call on the Raymond Navajo Reservation. They also cover the surrounding non-reservation areas in southern Cibola County, New Mexico. And they rolled on every call with N100 respirators, full face shields, gowns, and that is how they went to every call. But many agencies didn't have the benefits of that level of protection in the beginning, which really made those protocols very necessary. But that was a little bit about personal protective equipment and strategies to protect our providers. But what about protecting patients, providers too, from residual infectious particles in the air and on surfaces in the backs of ambulances? I mean, would you feel comfortable nowadays putting your child in the back of an ambulance, just like this one, thinking about the potential contamination from previous patients, from providers themselves, et cetera? This was something that prior to COVID didn't really receive much industry attention, though there's been studies in the literature for years that have talked about just how dirty the backs of ambulances are. This one was a 2007 study from pre-hospital emergency care, studying the prevalence of MRSA on ambulance surfaces. And despite, quote, standard cleaning, unquote, ambulances tested in the study had a significant degree of MRSA contamination. So this is before COVID. We were doing a terrible job of taking care of cleaning out the back of ambulances. And here we have COVID on scene. This kid is fine, by the way. This was another staged photo. That was my daughter, who was very much acting the part for a journal article about pediatric respiratory distress. But I mean, nowadays, looking at this, there's no way that I would want to put my child in the back of an ambulance like this without knowing that it was fully cleaned, not just for COVID, but for other things. So COVID has changed everything, and this is an example of how COVID has changed things for better, because now we're paying a lot more attention to the cleanliness of the back of the bus, so to speak. And so this is typical of what many EMS agencies are doing now. From Acoma EMS, the device on the left there on the cot is a fogging device. And they're just airing out their frontline ambulance there after fogging it out, and making sure that it was clean after a call. There's another picture of the device with the material or the liquid that they put in it. It's not an endorsement of the specific product, but just an example of what EMS has been using. And it's actually typical of stuff that they were using in retail establishments as well. Certainly hoping that this will be a permanent issue, even though we've kind of learned that maybe COVID isn't as virulent once it's on flat surfaces. The other stuff that's in the back of ambulances certainly is. So hopefully this will become a regular process even after COVID. This is another piece of Acoma equipment, 3 different sizes of UV devices that they UV their equipment with. The small one is for things like stethoscope. The medium is for like a bag, and the big one is for the station and for the back of the truck. And you can see there it is in the back of the truck. As it's after a call. Their goal was to run it for a full 60 minutes after each call. And of course, that creates a significant delay in availability. Luckily, they, like other agencies, have multiple vehicles to use. And so they could use a different ambulance if this one was still going when another call came in. But really, an important way to try to clean the back of the ambulance after a call. So that covers changes to dispatch, changes to treatment guidelines, and to personal protective equipment, and disinfection of the EMS work environment. Those changes are aimed at directly protecting providers from the virus and reducing chances of contacting the virus while unprotected, as well as protecting patients from non-infected patients from becoming infected iatrogenically. But EMS providers have also embraced community and public health initiatives aimed at community infection control, efforts that have really affect the public, their patients, and also, of course, the EMS providers themselves. And as you know, or as you may know, I'm very involved with getting EMS involved in public health, and this was a very natural outgrowth of that. One big aspect of this was having EMS involved in COVID testing, which was something that Pueblo of Laguna embraced early on. To run the Pueblo of Laguna's COVID testing program, they assigned a Laguna Fire Rescue paramedic lieutenant into the Emergency Operations Center, and she was installed as the testing group leader, and that is her there on the left. So at the height of COVID, they were having daily testing pods throughout the Pueblo to test for COVID and to make sure that they had an idea of where the infected patients were and how the disease was spreading through the Pueblo. Luckily, at the outset, the Pueblo remained COVID-free for quite some time while they got all of this infrastructure assembled. But as soon as it spiked in New Mexico, it made its way to Laguna, and they had to develop a contact tracing team as well. And so one of the other EMS lieutenants from Laguna became the contact tracing group leader and really learned about contact tracing. And again, at the peak was led a team of about 15 contact tracers who were chasing down every lead when it came to possible contacts with infected people. And they were able to respond rapidly to outbreaks and really played an important role in reducing spread. But of course, what we were all waiting for was the vaccine. And both the Pueblo of Acoma and the Pueblo of Laguna separately chose to partner with the New Mexico Department of Health to distribute COVID-19 vaccinations. They were two of only 3 tribes in New Mexico that went with the Department of Health instead of Indian Health Service for their vaccines. Both of them designed and implemented drive-through vaccination operations well before any such operations began elsewhere in the state. And though the details of each operation were different, they both used EMTs and paramedics almost exclusively to provide vaccinations and post-vaccination monitoring. This was the first shot given to a tribal recipient of a COVID-19 vaccination in the state of New Mexico. That was on December 16th of 2020. And that is an Acoma Fire EMS lieutenant giving, and he's an EMT intermediate, giving the shot to the lead health commander at the time of the Pueblo of Acoma Health Command. And that afternoon, Pueblo of Laguna began theirs, and they started with their emergency and essential personnel as well. Now, both of those vaccination efforts were drive-throughs, and except for the on-duty personnel receiving shots like the previous 2 slides, everyone stays in their cars for the vaccine and for the observation period afterwards. So EMS providers give the shots, and EMS providers observe afterwards and check on those in the observation area. This is Laguna's version. They were lucky to have a large industrial complex that had that kind of had a tunnel that they were able to put their pod in to keep everybody out of the elements. Acoma's version was outside. Initially, it was under the awning at their casino, but thankfully we've got good weather here in New Mexico, and we were able to just move it out into the open so that we were able to have a much better throughput at the height of the vaccine pods. We had 4 lanes going, vaccinating folks in their cars. These 2 pictures here are especially important to me, at least. They are, of course, a documentation of an important public health initiative, which is remarkable in its own right. But the planning and the tribal self-determination that made these events possible is less visible, but certainly remarkable as well. These pictures certainly speak of the training of EMTs to function as public health workers and as champions of public health infection control. But they also highlight a tribe's effort to protect and respect its elders, and therefore its history and its culture. And finally, this EMT is vaccinating her grandparents. The two patients here are grandmother and grandfather, and I know them all very well. So just seeing that happen and seeing how important that was on so many different levels was really touching. And again, these pictures are used with permission. And just to be fair to Laguna, this is a similar photo right next door. The Laguna Fire captain is in the operations vest, and he is watching and photographing his wife getting her vaccine from one of the Laguna Fire lieutenants. So that was all, again, very much a community effort to make sure that the community was protected. The vaccine pod went very well and very quickly got a large segment of both pueblos vaccinated. And we were able to then turn our attention somewhat to the in-home vaccination of homebound tribal members, as some of them were truly too fragile to be driven to the drive-through vaccination pod. And for that small segment of the population, we would go out and do the just give the injections and the post-injection observation in the patient's home. Now, obviously, that was much more logistically intensive because you could only do one or maybe two or three if there were several patients in the home that needed to be vaccinated, but you can only do just a few at a time. And this was when we were out there on one of the early runs to do that. We've really streamlined the homebound vaccination process. This was one of the Laguna paramedics on the left and me returning after making several vaccination house calls. But that was, something that was really important once we were able to get the vaccine pod running so smoothly. Of course, the big thing now is pediatric vaccines. Pueblo of Laguna has administered a total of over 7,000 vaccines to Pueblo members, employees, and residents of neighboring communities. So the big push is now for kids 12 to 15. And this slide is now already out of date, as they held their first pediatric vaccination pod last Wednesday, and that went really well. So just to wrap up, I mean, a lot of things have changed for the good, and for the better as a result of COVID-19 when it comes to EMS. EMS personnel are now a lot safer, and I think the patients are too, because of the changes in provider PPE and in equipment cleaning and sterilization. And that's gonna move forward. We need to do that as an industry to make sure that this moves forward. But the EMS's integral role in public health, which again, you hear me talking about all the time, the integral role in public health with testing, tracing, vaccination, that's going to outlast COVID as well. EMS's involvement in population level COVID-related infection control has really proven that EMS providers and EMS systems are excellent and natural public health partners. So it's going to be really interesting to see how this partnership matures over the long term in Laguna, in Acoma, and elsewhere, as hopefully this message continues to get out. This is, I did have to include a reference slide. Basically, it's almost all personal experience plus downloads from the Pueblo of Laguna's COVID-19 Facebook page. But I really want to thank all of you very much for your attention and the opportunity to speak today. And thank you very much to the EMTs and paramedics from Acoma and Laguna and Pine Hill and To'Hajiilee, who are also shown here, who continue to work hard and make a difference in the COVID-19 pandemic. So thanks again, and I'm happy to answer any questions that you may have. Let's see if there's some.
I just wanted to echo your thanks, Chelsea, and thanks to you for your leadership in this space. And really showing us vivid and successful examples of stretching and defining new frontiers in the practice of community paramedicine and the ways that EMS services can partner with communities. I'm not aware of anybody who's really working in this space and moving forward in the way that you and your team are. So thank you again for taking time to join us.
Well, thank you. I appreciate that. One comment in the chat: as a public health trained paramedic, I love seeing this, from Kate Elkins. One thing that we are also looking at that I did not mention here is the topic of the public health nurse, very important in tribal areas. But that seems to be a challenging position to fill sometimes. So we are very interested in Laguna in looking at piloting a public health paramedic program, and in particular the paramedic who led the testing group, I think, will be our public health paramedic pilot. So maybe in a future talk like this, we'll be able to mention more of that.
Wonderful. Thank you, Chelsea. Very much appreciate it.